Welcome to the University of Michigan Dentistry Podcast Series, promoting oral health care worldwide.
A few years ago, we had several students which failed sections of the dental anatomy on the national board examinations. And we have always taught general dental anatomy and never specifically to the boards, but we thought we'd better review this. And in reviewing it, found out something rather interesting. Run across one question which about 95% of the students got right on their final examination, but the exact question, word per word, on the national boards, 65% of the same class got it right. And we come to the conclusion that, a lot of this technical, detailed information which you're not currently using is easy to forget. It's not that you don't know the material, but it's just you've had so much that you start forgetting some of the details. So therefore, I think a review is really important in trying to freshen yourself up on a lot of these details that you may not be using regularly. Gone over several of the past year's examinations, many of which are available, and found out several general trends which are rather interesting, which I'll share with you. Number one, there's been a lot of repeated questions on the national board examinations. In some pages, I found as high as 50% of the questions were repeats from former years. So I think looking at old exam questions is generally a good idea and a good study guide. In looking at the actual breakdown of the dental anatomy section, the national boards, found that about 50 to 60% of the material covered on there is material that was actually covered in the dental anatomy class. It dealt with tooth morphology specifically. About 20 to 30% of it dealt with occlusion. And the cusp-fossa relationships on a regular class 1 type of occlusion is very, very strongly hit on the examinations as to what tooth hits what tooth in the opposite arch. And I think basically, if you remember that the maxillary anteriors are the wider of the teeth, and the mandibular anteriors are very narrow, so by the time you get to a cuspid, you're a half a cusp off. That allows for your intercuspitation in the posterior area. But because the mandibular molars get significantly wider mesially distally, by the time you get back to the third molars, they're pretty much ending up together because your maxillary molars are a little narrower mesially distally. So if the working and balancing and protrusive relationships are hit very heavily on the exam as far as how these teeth move, and it's something that you need to review rather thoroughly. Jaw movements in relation to protrusive, and this Pasquale's diagram is used on almost all the exams, and they want you to know each of the details of its diagram. Found that also another 10 to 20% was oral histology, oral physiology, oral reasons of gross anatomy and muscles of movement. Some orthodontics on it, particularly angles classification, 1, 2, and 3. You should know those classifications thoroughly because they're hit significantly. And there's been some in relation to periodontia, particularly the anatomy of the periodontal ligaments and things of that nature. Interesting on the exam, as it is written, they have totally eliminated the term buccal and the term labial, and they substituted into it facial for just the surface next to the face all the way around. This is a common term, but they've elected to use that throughout. So instead of having buccal cusp, they've got facial cusp. Instead of having angles, they'll have a facial mesial angle, which may sound a little bit different, but if you stop and think a little bit, it'd be pretty easy to put it together. I've used the term buccal and labial all my life, and in the review here, I'll probably try to use facial, but end up using buccal and lingual even here. Also found on the examination that there was very little reference to anthropology. In old exams, they did a lot with the development of the dentition as different animals of rodents and canines and things of that nature, and found that this has been pretty much eliminated in the recent exams, and just as well, I'm not sure that it's of great value, and we don't really teach it that much anyways. I think it'd be best to take and go through tooth by tooth and just review the terminology and the specific anatomy of each of the teeth. And this will go through rather quickly on each of the teeth, but point out the areas that they seem to be hitting rather heavily. We can start with a central incisor, maxillary. I think you recognize the key off the bat that we have a difference in incisal angles. The difference also is in relation to height of contour mesially distally. On the distal, your contact area, your height of contact is going to be closer to the cervical. And this is something that is hit and asked frequently, and this also occurs throughout the anterior teeth. It's all the maxillary anteriors, all the mandibular anteriors. The contact area on the distal is closer to the cervical. There's a fairly significant difference. The contact is closest to the incisal on the mesial of the maxillary central of all the other maxillary anterior teeth. If we look to a mesial view here, we find that our cervical line curves very significantly towards the incisal on the mesial, and much more than the distal. And again, this is a principle of all of the anterior teeth, maxillary and mandibular. The mesials always curve closest to the incisal, closer than what the distal does. Height of contours are referred to very commonly in all of the teeth, and I'll review most of those with you. It's in the cervical third of the majority of the teeth, including most all the anterior teeth. And of course, on the lingual, we've got a fairly prominent cingulum on our maxillaries, and the height of contours in the cervical third where the cingulum is. We've got the concavity on the lingual of the anteriors, and this being termed the lingual fossa. Lingual fossa ends in a lingual pit. This is more characteristic in lateral, but also can occur in your centrals. And of course, your cingulum, we've got cingulums in all anterior teeth. We have no cingulums in any of the posterior teeth on it. The roots of these teeth are commonly referred to in regards to the shape of them. If you remember, being the headstone of the arch here, we're triangular in shape. We're broad across the labial, or they would call it facial surface, and we have a tendency to narrow significantly as we come to the lingual. So we end up with a triangular root. And with our shape of our root also comes the shape of our root canals, which are frequently talked about in these teeth. And our root canal on this tooth at the, say, the cervix of the tooth, or the area near the cervical, is simply triangular in shape, as the root is triangular. Maxillary anterior teeth are characterized by having a blunt apex, very rarely being curved. It's just a triangular root, not real long, and blunt in its apex. Laterals are frequently longer in their root. Cuspids are significantly longer in the root. This is just a short, triangular, blunt-shaped root. This has pulp horns in the occlusal, and the pulp horns in a young tooth would be coming up very significantly, a mesial and distal pulp horn. Very important, and this forms into a pulp chamber in the occlusal portion of the tooth and follows into the root canal that goes down the root portion of it. This particular tooth develops from 4 areas of growth. 3 of them develop on the incisal area. We have the, frequently when these teeth first come in, we've got mamelons. We've got a mesial and a middle and a distal mamelon. Oftentimes it'll develop into little depressions that come down the labial surface. Sometimes you can see them, sometimes you can't. But these will be your developmental depressions coming down the labial surface, mesial developmental depression, distal developmental depression. And our 4th growth area on this tooth is our cingulum. Now, this cingulum starts out small, and it continually gets larger in the maxillary tooth. And as you go to the lateral, it's a much more prominent cingulum. You go to the cuspid, it's a very significant cingulum. Time you get to the first premolar, it's a cusp, actually. Second premolar, it's a taller cusp, almost equal to the second, or to the facial cusp, or buccal cusp. By the time you get to the first molar, this cingulum here has developed into such a large cusp that it's actually larger than the facial or buccal cusp, and it becomes the predominant mass and bulk and height of the tooth as it goes back through the molars. So it's our fourth growth area in our incisors on it. Well, let's look to a lateral. One of the things that evidently we didn't spend a lot of time on, because I found that about 50 to 70% of the students were missing, and this is the laterals are one of the most variable crown forms of any tooth in the mouth except for the third molars. And this deals with what is called peg laterals, malformed, mal-shaped lateral incisors. Lateral incisors are commonly congenitally missing. Probably the second most congenitally missing tooth is the mandibular second premolar. But these are commonly missing also, and sometimes when they do form, they form into what is called peg laterals. This is a very typical peg lateral, a conical shaped tooth which it just doesn't have much form at all. If we look to, well, one other thing I should point out with our central before I leave it here, and that is the incisal view of it. If we look down on the incisal view, generally speaking, our incisal edge is located directly over the center of the root. And our cingulum is either located in the center of the lingual surface or slightly to the distal. It can be either. I haven't found questions in that regard, but it's certainly never to the mesial. It's either centrally or slightly distally located on the cingulum. As we go to our lateral from an incisal view, again, we find that our incisal edge is located directly over the root. A question which again pops up frequently. We find in our laterals that our distal incisal angle is the most rounded. This one doesn't show a real good distal incisal angle because it's been worn. This probably shows a better virgin distal incisal angle, which is normally rounded, which makes for our height of contour on our mesial and distal surface to be closer to the cervical. It's closer to the cervical on the mesial than the centrals were. At the distal is considerably closer than either the mesial or the lateral or either one of the centrals because of the rounding and the shorter crown on this tooth. Labial surface, again, very similar. We've got our heights of contour on the labial and the cervical. We've got a prominent cingulum on it. Again, we've got the same lingual fossa. The one characteristic that's significantly different here, and that is our marginal ridges on the lingual, distal marginal ridge, and which should be located here, and a mesial marginal ridge, are significantly heavier in their roll, and the most heavy marginal ridges of any of the anterior teeth, maxillary or mandibular. It also frequently has a pit in the lingual surface, and that pit is the most frequently found pit, and often a significant pit, oftentimes requiring restoration on any of the anterior teeth. Our cervical line, again, has a tendency to come close to the incisal edge on the mesial, and on the distal, well, see, that was distal, so the mesial over here comes a little closer to the incisal edge than what the distal does. Sometimes hard to see, but if you want to break it down and measure it real accurately, it's always a little closer on the mesial than it is on the distal. The root form on this tooth is broad to the labial, as is a general feature of all of our single-rooted teeth. They're broader on the labial and narrower on the lingual. But this particular root form is not triangular like the central. It is said to be oval, or I call it egg-shaped, broader on the labial, narrower on the lingual, but an egg-shaped oval root, which makes for an egg-shaped oval root canal in the inside of the root. We generally do not find any root concavities on a maxillary lateral. If you find a tooth with root concavities, it's generally not a maxillary lateral. So no root concavities on either the central or the lateral. These are the only two anterior teeth that do not have root concavities, as the maxillary central and maxillary lateral. We have the same basic pulp horns with your mesial and distal pulp horns. In this, sometimes we'll actually have a small middle pulp horn, this being developed from 3 different lobes, and we'll have, you know, a mesial pulp horn and a distal pulp horn and possibly a middle pulp horn. But the mesial and distal ones are the ones commonly referred to. Let's look at our mandibular incisors while we're on incisors and compare them. Our mandibular central incisor is said to have an incisal edge which is located slightly to the lingual of the mass of the root on it. So if we were to look at it straight down from the incisal or from a mesial view, they say the incisal edge is slightly to the lingual. I find this a little difficult to see, but it's a technical situation which I think if you think of the occlusion on this tooth is kind of pushed into the lingual by the way that normal class 1 occlusion is, and I use that to help me remember the lingual edge being to the lingual. If we look to our height of contour on the cervical, we find that they're similar to the maxillaries, but they're hard to discriminate which is mesial and which is distal. The textbooks say that the mesial is a little closer to the incisal ridge than what the distal is, but it's so difficult to tell, and these teeth are so perfectly symmetrical that these are the teeth that it is almost impossible to tell the right from the left. On our labial surface, our tooth is very wedge-shaped. We find that our line angles on both the mesial and the distal are equal in their sharpness. Our height of contour mesially and distally are very close to the incisal edge and very much equal on both the mesial and distal. The tooth is pretty much proportioned like an even fan over the root. It's centered directly over the root as far as the mesial distal dimension of the tooth is concerned. The root on centrals and incisors is said to be more bow or ribbon shaped. It frequently will have concavities, root depressions on both mesial and distal area. They don't have to, some of them have none, but it's very common to have these. And again, where you've got significant depressions, you have to think in terms of the root canal inside of the tooth. The root canal is commonly and normally a single, very long, narrow root canal from the labial to the lingual, but can, on occasions, actually divide into 2 different root canals, oftentimes in the apical third. I have another mandibular central, one of the few that I could find that shows some mamelons. Mamelons are the commonly found when teeth first erupt, but they very quickly and rapidly disappear as teeth become in occlusion and start to wear. One of the things we want to remember is that primary teeth do not have and never have mamelons on them. Mamelons occur in the growth centers, and normally we have 4 growth centers on all of our anterior teeth, the same growth centers, 3 on the incisal surface, and then 1 in the cingulum area. The cingulum on the maxillary centrals is much, much smaller than the maxillary, or on the mandibular centrals. The cingulum is much smaller than on the maxillary centrals. And our concavity, lingual fossa area, is just a general fossa area with very little in the way of marginal ridges. The marginal ridges are there by location, but it's difficult to identify them because their mandibulars are generally pretty much flat all the way across the lingual surface, and the lingual fossa and the marginal ridges are all at basically the same height of contour. One of the common characteristics in the maxillary central too is the labial surface, or the national boards we call it the facial surface, is flattened. We have a height of contour close to the cervical, and then it flattens as it comes up to the incisal. Want to remember the incisal wear pattern. Typically in the mandibulars has a tendency to wear towards the labial, so that our labial is worn the most and our lingual is the highest. And in our maxillaries, it'll be just exactly the opposite. It wears from the lingual, pretty much based on the way that the teeth occlude. If we, think of our occlusion as being of such, we're going to be wearing the labial more than the lingual or the incisal on the mandibular, and we'll be wearing the lingual more than the labial on the maxillary. So let's look to a mandibular lateral. Very similar to the central, generally speaking, slightly larger in size. It has a significantly rounded distal incisal angle, and this is one of the things that helps us to determine right from left on the mandibular laterals. We also have, when we look at it from the incisal view, a cingulum, which usually prominently swings towards the distal and doesn't evenly bisect the tooth from the labial to the lingual. And this swinging of the cingulum is kind of as it is turning in the arch. The incisal edge appears to be twisting in regard to the cingulum, or starting to turn the arch, and it's not perfectly symmetrical in that regard. Generally speaking, on the distal of our mandibular laterals, we will practically always have a root groove or root concavity. Sometimes on the mesial we'll have one, sometimes we won't. On the distal, we frequently and fairly routinely have a incisal concavity. Again, we have a very flat, broad, ribbon-shaped tooth, root rather, and this also gives us a rather long, ribbon-shaped root canal in here, broad from the facial to the lingual, and very narrow mesially distally. Again, if we needed to look at the root specifically, we would find that the labial portion of the root is slightly wider than what the lingual portion is, and so is our root canal. Same basic pulp horn design in the tooth. But the common term on description on these is the flat, broad root with a very flat, broad root canal in them. Frequently be a little bit more pointed on the apex. Sometimes they'll twist slightly to the distal. Let's look at our cuspids, if we may. Our used to be called cuspids when I came through. They're technically called canines now, and on the examinations they'll be termed canines exclusively, but again I may revert back to the cuspid term, primarily in so much as they are the only teeth in the mouth that have one single cusp, or our canines. These are the teeth that are exaggerated in all the carnivorous animals, of the dogs and cats and lions and tigers, have very prominent, large canines. If we look to our maxillary canine, we'll find that it is the longest tooth in the mouth, from the incisal tip of the cusp to the apex. But the crown is not the longest crown. The mandibular canine crown is longer. The maxillary canine is said to have a short, fat crown. It is broader mesially distally than a mandibular canine, and broader than your maxillary lateral, and has a tendency to have a shorter crown. It still has the same curvatures in the cervical areas, except they're becoming less. This is the most posterior tooth in which we are able to identify these cervical curvatures. As we get to the posterior teeth, they become so indistinct and so little that you really can't use them to identify the tooth, or they aren't really significant. We notice that on the mesial surface, that our incisal contact area, height of contour, is much closer to the incisal, as I said, occurs in all the anterior teeth. But on the distal surface, we get quite rounded. Looks like this one's been chipped a little bit there, but it gets fairly rounded on the distal area here, and our contact area is with the bicuspid now, and this is below the marginal ridge, and so it has to be closer to the cervical, and it's almost getting into the mid portion of the tooth on the distal here. This leaves us with a mesial surface which is frequently quite straight, and a distal surface which has a much larger concavity at the cemental enamel junction. If we looked at the line angles, we'd find that the mesial facial line angle very sharp. Our distal facial line angle fairly sharp towards the incisal, but as we get towards the cervical it rounds rather significantly as it turns the arch and starts to match up with our first premolar. Single cusp, our mesial cusp ridge, shorter than our distal cusp ridge, which has further to go to get to the contact area. So there's a difference in the length of our incisal ridges, mesial one being the shorter one. Again, generally we find that the cusp tip is located fairly close to being centrally located over the center of the root. Sometimes the books will actually say that the cusp tip is to the labial of the mass of the root. And so I suspect for the exam we'll want to keep the cusp tip here located slightly to the labial of the center of the mass of the root. Remember our maxillary central and lateral were directly over the center of it. Mandibular central and lateral, the incisal edge was slightly to the lingual of the mass of the root, and on our cuspit, the incisal edge is said to be slightly to the labial of the center of the mass of the root. We have a very prominent cingulum on this tooth, leaving for a rather significant roll right at the cervical here. And this prominent cingulum is much, much more prominent than the mandibular tooth. We have better lingual anatomy, as we do in our maxillary incisors, insomuch as we'll have more of a cusp ridge. This is called a lingual cusp ridge, which comes down through here, along with our mesial marginal ridge and distal marginal ridge, which are, again, usually more developed in the maxillary than they do in the mandibular. Frequently, this will leave us some fossas, our distal lingual fossa and mesial lingual fossa. Occasionally, these will actually pit, and there'll be a mesial lingual pit and a distal lingual pit, but not real common. You can see this lingual anatomy much more prominently in the maxillary than you can the mandibular on it. This tooth may have root depressions on both the mesial and the distal. Not as common as mandibular, but they do have depressions in the root occasionally, and frequently, again, they're very broad from the facial to the lingual and very narrow from the mesial to the distal, which gives us a very oval-shaped root canal inside the tooth. But again, we're broader on the labial of the root and narrower on the lingual, just as we, round the arch of the mouth. If we look to our mandibular canine tooth, we'll find that it generally has a very long, narrow crown. And the crown is actually longer than what it's so white you can hardly see it here. The crown is much longer than what the maxillary canine is, and it's one of the longest crowns in the entire mouth. It is the longest crown statistically in the entire mouth. But the root is not quite as long, and as a result, we find that the maxillary canine is the longest tooth in the mouth. This is about the second longest tooth in the mouth. This particular tooth, I think, is longer than the one we showed here, but the maxillary, but statistically it's not quite as long. One of the things I didn't point out that we ought to remember, and that is that with our height of contour on our maxillary teeth, we frequently have a very significant roll on our height of contour, which is in the cervical third yet. And this will leave a dip or a concavity at the cemento-enamel junction, particularly on the labial. And the root has a tendency to be pretty much straight and flat, ending at a fairly blunt root tip. On the mandibular teeth, we find that this height of contour is much closer to the cervical and we don't end up with a concavity significantly there, and that the root frequently is curved instead of being flat. Actually, there's a fairly smooth facial arc that begins at the cusp apex and continues on the facial surface to the root apex, where the apical foramen is normally located. And so it's a much different design in the labial outline, which is common. And the other major design difference from a mesial or distal is our lingual. Our lingual cingulum is much smaller, as all of our mandibular teeth are, and we have a much more significant concavity in the lingual surface. We are more difficult picking out the lingual ridge and our lingual fossas. Our marginal ridge is not as well developed and on the lingual surface, but all the anatomy is basically there and termed accordingly. We frequently have concavities in the root of this tooth. The concavities again influence our root canal, and our root canal again is very commonly broad from the labial to the lingual, very narrow mesially distally. Occasionally this tooth will be bifurcated in the root. It is said to be the only anterior tooth that can have two roots, and seems to be a common catch question for many exams. Only anterior tooth with two roots is the mandibular canine. We have heights of contours on the labial, which are very similar to the maxillary, except the crown is just much narrower. It's just held over the root much closer. And this tooth in particular is said to have a very flat incisal or mesial surface, that going from the height of contour, which is again closer to the incisal edge than what the distal height of contour is, going from the mesial height of contour down to the root, we end up with a flat surface here on the mesial. The distal, because of the bulkiness of our height of contour on the distal, similar to the maxillary but not as prominent, frequently end up with a concavity on the distal, and they don't refer to that flat surface, but this is frequently considered a flat surface on the mesial. The cusp ridges, again, are shorter on the mesial cusp ridge and longer on the distal cusp ridge. Although in relation to the mass of the root, the cusp is frequently placed pretty much right over the center of the root. The distal being kind of stuck out from the root surface on it. Maxillary premolars. We're dealing with two cusp teeth. They're oftentimes called bicuspids, again the term that I learned, because of two cusps on the tooth. Premolars is the proper and technical term which will be used in all the exams. With our maxillary premolars, we'll find that we have very sharp, definite, specific anatomy. And generally speaking, I think we can find this with the first maxillary premolar, the same with the mandibular first premolar, the same with our maxillary and mandibular molars. And that is, the first one has very specific anatomy, and as we go to the second premolars, the anatomy becomes more variable. As we go to our second molars, the anatomy becomes more variable. As we go to the third molars, it becomes extremely variable. So our first, whether it be premolars or molars, are the most consistent anatomy in it. Our maxillary premolar, we develop an occlusal surface rather than an incisal edge, and we're developing two cusps, which would be the facial cusp on the exam and your lingual cusp. The lingual cusp is the one that is swung to the mesial, and this occurs on both first and second maxillary premolars. Marginal ridges we now have, mesial and distal marginal ridges. We've got the whole interocclusal aspect of our tooth. We've got a fairly long central fossa on our maxillary first premolar. Maxillary second premolar, we got a very short central, I shouldn't say fossa, groove. We have a long central groove. We have 4 developmental grooves coming out on the occlusal, which are termed by the direction in which they're going. Your mesial facial developmental groove, mesial lingual developmental groove. The most prominent developmental groove is your distal facial developmental groove. It's the largest, and it's largest because of our cusp ridge. Our maxillary cusp ridge has a tendency to be straight and flat, but not parallel to our central groove. It's constricting and narrowing as it comes towards the mesial. And if we think of this sitting next to a narrower cuspit and distal of it sitting next to a broader second premolar, we'll recognize that this is flowing in the anatomical aspect of the mouth here, the mesial being narrower. We frequently will have a groove which crosses the mesial marginal ridge. This particular mesial marginal groove is generally 99% present and is frequently referred to as a specific problem area of the restoration of this tooth, and something that they frequently will test on. We have 4 developmental growth centers, 3 on the labial again, or the facial, and 1 on the lingual. Oftentimes this will leave a little bit of a depression down on the labial surface, more frequently on the mesial, I guess I got to try to call it facial surface, mesial-facial developmental groove, and frequently will leave a ridge, a more prominent ridge running down here, which oftentimes may be called the Buccal Ridge, coming down the center of the buccal surface. We've got triangular ridges, which come from the cusp tips into the central sulcus area of the tooth, the central sulcus being the general depression between the cusp tips, occlusal table being that between our cusp ridges and our marginal ridges, the central portion of it being our occlusal table. This whole area frequently called a central fossa, central sulcus area down through the tooth. If we look at the mesial surface on it, we will find that this tooth is characterized by having a concavity. This concavity is probably the most important concavity in the entire mouth and is generally always hit on an examination. The concavity frequently comes up into the crown and up very close to the contact area of the tooth. And this concavity is very important from many respects, oral surgery, perio, restorative in particular, and is very commonly referred to as the mesial concavity of the maxillary first. Seconds do not have a concavity on the mesial, nor do we have concavities on the distal of either the first or the second. So the only maxillary premolar having a concavity is this first. Now this premolar has 2 roots, be a facial root and a lingual root. Sometimes, about 50% of the time, they'll have a single root, which is not uncommon. But in most all instances, they'll have 2 root canals. Whether they have a single root or whether they have a double root, we generally have 2 root canals in our maxillary first premolar. Occasionally, we'll even have 3 roots on this one. This one's been known to buccal root bifurcate into, similar to the maxillary first molar, into 2 roots, but that's not a common feature. Our pulp canals or I should say our pulp horns are generally located under the cusps, and according to the size of the cusp is according to the size of the pulp horns. Common question is in premolars or molars is to determine which pulp horn is the largest. Well, you just have to remember which cusp is the largest, and you automatically know which pulp horn is the largest. Your pulp canals, the pulp chamber, and the pulp horns are really a miniature mimic of the outside of the tooth. If you know the external anatomy, you almost always can apply it to the pulpal anatomy because it follows very similar. So we've got a very prominent, large buccal pulp horn under this more prominent buccal or facial cusp, and a smaller lingual pulp horn under the smaller lingual cusp. Our height of contour is said to be in the cervical third on the buccal, but on the lingual this changes, and this is the first time it's changed. It comes into the center of the tooth. We got a fairly even convex lingual surface, and our height of contour on the lingual is in the center of the lingual surface. If we look at our distal surface, again, we're not seeing a whole lot different. The height of the cusps are prominent. We have no significant curvature to the cervical line, either mesially or distally. We do not have a groove coming over the marginal ridge. And actually, the marginal ridges, generally speaking, you can make a statement that the mesial marginal ridge is further from the cervical, or closer to the cusp tips, whatever way you want to call it, and the distal marginal ridge is closer to the cervical. There is one exception to this, and of course that's the one that always appears on the exam, and that is the mandibular first premolar, and we'll go over that when we get that. But generally speaking, all premolars and all molars follow the same pattern, and I try not to repeat it in every one. But our distal marginal ridge is closer to the cervical than what the mesial marginal ridge is. If we look to the occlusal surface, we'll find that the central sulcus area, or the central groove area, is located pretty much directly over the center of the root. And again, if you think in terms of your occlusion, and we put a mandibular premolar in here, we'll find that the mandibular premolar normally would occlude or articulate right there, and that places the stresses right over the center of the root. And this is, again, generally true of most of our maxillary teeth, and generally the principle is true of most of our mandibular teeth. And that is that mandibular teeth, our cusp will pull more into the center of the tooth, and actually on the mandibular first premolar, it is right over the center of the root in the tooth. Or maxillary second premolar, and again I'll just hit the primary differences. The differences in our cusps heights. We have very significantly larger lingual cusp. It's not quite as large as our buccal cusp, but it's getting close to it. When we go to our first molar, it'll be actually larger than our facial or buccal cusp. We get less distinct here. If we remember our first, one of the characteristics of the first are the line angles. The buccal line angles are said to be the sharpest line angles in the entire mouth on our buccal of our maxillary first premolar, and on our seconds, our line angles start to become rounded, and the tooth becomes very much significantly oval. One thing I didn't point out in the first, which is also characteristic of the second, and that is the distal lingual area of the tooth, the line angle, is the most rounded, which swings our cusp prominently to, lingual cusp prominently to the mesial of the tooth. I got the wrong angle there, looking at it from here. If you look at the lingual cusp, it's prominently pointing out to here, so this would be our distal lingual line angle, which is the most rounded one. Common characteristic of the second is we have much heavier rolled marginal ridges and a short central groove, or oftentimes the central groove will actually end into a central fossa. Common question is which posterior teeth have central fossas, and our maxillary second may and does frequently have just a central fossa, or a very short central groove with heavy rolled ridges. Let's look on to our mandibular premolars. As I indicated earlier, common characteristic is our cusp. We have two cusps yet, and our lingual cusp is very small. Our buccal or facial cusp very large and right over the center of the root in the tooth. Our height of contour is in the center, or close to the center portion on the buccal, and on the lingual it's said to be up in the occlusal portion. So we've got a different, significant different height of contour. This tooth is the crown of the tooth is at a different angle than what the root is. The crown of the tooth has a tendency to be located tipped towards the lingual, something which is frequently referred to, and the root is at a different angle than what the crown is. Our occlusal table is actually at about a 45-degree angle to the root on this tooth. We commonly on this tooth have a very strong transverse ridge. It's the only transverse ridge technically in the permanent dentition. We have two very distinct pits on it, a mesial pit and a distal pit. Sometimes the distal pit will have a little bit of a groove in it. Generally, a groove does not cross the transverse ridge, but occasionally does. We have this lingual cusp, which can be located either towards the mesial or towards the distal. It's not reliable in which direction, or centrally located. The one thing that is very reliable and commonly referred to is the groove which comes out of the mesial pit. And this is a mesial lingual groove, the only mesial lingual groove we have in the entire mouth, and it seems to catch quite a lot of attention on it. The root, the same basic as our maxillary premolars, broad to the labial, narrow to the lingual. Frequently will give us our root canal. Occasionally this tooth can be bifurcated in the root itself. Occasionally the root canal may also be bifurcated. We see a tendency towards a bifurcation here. And needless to say, we can have concavities on the root, either mesially or distally on this tooth. It's not quite as broad from the facial to the lingual as what our maxillaries are, and instead in the maxillaries we call the occlusal outline more egg-shaped or oval. In our mandibular premolars, since this distance is narrower from the facial to the lingual, it's more rounded, except this mesial lingual angle on the first is very significantly flattened by the groove that comes out and comes across this mesial lingual groove. So we got a round tooth with a flattened angle on the mesial. And again, we're against a cuspid here, and it kind of blends in with the flow of the arch as it broadens out. Our mandibular second premolar is more roundish in its total outline form. But we have a variation in the anatomy on this, which is frequently referred to on many exams, and that is that we have the H, the Y, and the U-shaped occlusal anatomy. Lingual cusps on these teeth are becoming much more prominent and much higher, although they're not nearly as large as the buccal. Our central groove sulcus area is still located towards the lingual, and the bulk of our mass is this large buccal cusp. This buccal cusp isn't directly centrally over the root, but it's certainly tipped in much more than the lingual cusp, which is prominently out on the lingual surface. Height of contour on the lingual is more in the center of our lingual surface, and actually it's said to be in the lower center portion out here on the facial aspect of the tooth. When we have the three different anatomies on this teeth, the U, H, and Y, this leads for a different occlusal anatomy on the tooth as far as our terminology is concerned. And if we have a Y-shaped tooth, we frequently will have a central fossa, or a central pit area here. And again, one of the teeth that can have a central sulcus, central fossa, central pit area, and the groove which comes out to the lingual is called a lingual groove on this Y-shaped tooth. If we have an H-shaped tooth, we really don't have a lingual groove. And a U-shaped tooth has no lingual groove at all. But when we get a Y-shaped tooth, again, we have commonly three prominent cusps. And so this is one of the few teeth that can be a three-cusp tooth. The other three-cusp tooth is commonly your maxillary third molar, which can be a three-cusp heart-shaped tooth. But don't forget that our mandibular second premolar can be a three-cusp tooth also. More commonly, prominently two-cusp in the H and U shape. And maybe we'll look at this one as an H-shape type, where we've got a prominent, strong lingual cusp. The lingual cusp is generally always to the mesial, as our maxillary premolars were. And we'll have a central groove in here. We do not have a transverse ridge, distal pit, mesial pit, and our developmental grooves similar to what you would have in your maxillary premolar tooth. Our root is, again, broad to the labial, narrower to the lingual, much broader from facial to lingual, and narrower on the mesial distal aspect. If we really look at the widths of these teeth, we'll find that even though it's fairly round in its shape, it is very slightly broader from the facial to the lingual by a ½ millimeter or so. But the mesial distal dimension is the same, approximately 7 millimeters on an average, and this is the same for the first mandibular premolar, the same for both the maxillary and first and second premolars. They're generally all basically the same. We want to remember that in our maxillary anterior that we pick up quite a lot of additional width in our incisors and cuspit, and in our mandibular incisors and cuspit we're narrow, and that gives us this cusp difference, cusp fossa difference, and our premolars are all the same, maxillary and mandibular, in their width. When we get to the molars, it reverses, and then we make up for what we lost in the mandibular anterior, because the mandibular molars are going to be much broader. If we look at our maxillary first molar, again, the anatomy on it is very prominent characteristic, very similar in all of them, but we have a rhomboidal shaped tooth, which actually has the lingual being the more prominent, dominant portion of the tooth. And again, this is what is occluding in our mandibular central sulcus area here. So you'd kind of expect that to a degree. But our mesial lingual cusp is the largest cusp on the tooth. It is also the highest from the cervical. Sometimes we'll have a fifth cusp attached to it, a cusp of carabelli or a fifth cusp called. Sometimes it's present, sometimes it's not. We have a very strong oblique ridge. You'll need to know which direction it runs, from the mesial-lingual out to the distal facial across the tooth. And this is not crossed by a groove generally on the mandibular first. Very prominent, strong ridge. Occasionally we call it a transverse ridge. Most of the exams will call it a oblique ridge because of the way it runs across the tooth. Actually, our tooth is slightly wider across our lingual cusps than it is our buccal cusps. This is the first tooth and one of the only teeth in the entire mouth in which we'll have a broader mesial distal width across the lingual than we do the buccal, but it's very slight amount. We've got our central fossa, which is a very significant central fossa. I think it shows rather well in this tooth because it's picked up some stain. That's generally the central fossa area in here. And we've got our well-polished oblique ridge, and then our distal fossa. Usually we'll also have what is termed a mesial fossa on the tooth. It's not nearly as strong and prominent. But out of this distal fossa comes a groove, which is called the distal buccal groove, distal lingual groove rather, as it comes out and crosses the lingual surface of the tooth, and then frequently is called the lingual groove as it comes down the lingual surface. But it's a distal lingual groove is the basic term of it. It's one of the only distal lingual grooves in the mouth, but it is significant in so much as it does cross the height of contour on this tooth, actually dimples the height of contour in the first molar, and comes onto the lingual surface and actually will groove this lingual surface and form a concavity on the lingual surface. And this is generally the only tooth in the mouth that has a lingual concavity on the root. And being the only one, it commonly is a common exam question. So we got a lingual groove. And again, this leads for a root canal in this tooth, which is broader from the mesial to the distal. This is the only root canal we have in the entire mouth that is broader mesially distally and narrower buccolingually. And it again, the shape duplicates the shape of the root. If we look at the mesial aspect, we'll find that the lingual root is generally the longest root. Our mesial root is fairly broad, flat, and sometimes we'll have a concavity in it. Generally it will have one canal in it, but occasionally could have two. Our contact area is generally to the buccal, and it's generally to the buccal in all posterior teeth. In the occlusal third of the tooth, but to the buccal. Common question. This location of this contact area, or the height of contour, and in all the posterior teeth, by premolars as well as molars, it's generally located to the buccal. This kind of opens up a larger lingual embrasure. Remember, the term embrasure is a space which radiates in a V shape out from the contact area of the teeth. And this can be a incisal, or it can be lingual embrasure, facial, buccal embrasure. It could be a cervical embrasure. A cervical embrasure and an interproximal space are basically the same. So you don't hear cervical embrasure as much as you do an interproximal space, but a lingual embrasure is a very common term, and incisal or occlusal embrasure, the space actually radiating out from the two teeth which are in contact in that regard. Our distal buccal root is a much smaller root. Still a little bit broader labially, lingually, but getting much more rounded. Frequently will be straight, but pointing out towards the distal. The mesial buccal root frequently will be curved, and it'll actually curve towards the distal. Very commonly, we have a concavity on the distal surface of this Mesial-Buccal root. This is a very significant concavity, particularly when attempting to extract this tooth. One of the most common concavities outside the maxillary first premolar, mesial aspect of it, the mesial concavity, one of the most common concavities referred to is a concavity right here. And again, from a periodontal standpoint, it picks up calculus, and you can see a lot of calculus that this one is picked up right in here. And that is the cervical area of the distal buccal or distal facial of all of our maxillary molars. Has a rather significant concavity. So in talking about concavities, actually comes up into the crown. That's one of the more prominent concavities we want to refer to. Trifurcation here is closer to the crown, leaving a very short root trunk. The roots are fairly widely spread broader than the crown. Common characteristic of a first, very significant when you get involved into pulpal treatment and extractions and things of that nature. Let's go on to our second. Tooth is slightly narrower from the mesial distal, still has the same facial lingual width on it, and the facial lingual width is the widest, wider than the mesial distal width on our molars here. We've got the same basic anatomy in the occlusal. All the grooves and pits and fosses and what have you are the same. Occasionally we'll have a groove, quite commonly crossing this oblique ridge though. That's a common area of having a groove cross the oblique ridge. The groove coming out on the buccal is simply called your buccal groove. Didn't mention that in your first, but it's the same here. The groove coming out on the lingual, the distal lingual groove, does not commonly cross the height of contour on the lingual surface, and does not commonly groove this lingual root as it's coming down in here, so we don't have the concavity down the lingual root. The roots are all termed the same. They're frequently not trifurcated as close to the crown. We've got a larger root trunk. They're usually blunt in the apex of them. Again, they have a tendency to swing towards the distal, particularly your mesial buccal root, and the lingual root is usually the longest root. They're usually held underneath the crown so that they're not spread broader than wider than the crown. But we again have a significant concavity. Your distal buccal line angle at the cervical is frequently a very concaved area in here, which is a difficult area from many respects in restoring and working with the teeth. If we look at our third molars, we find that they're the most variable teeth in the entire mouth, and it's hard to study them greatly. But generally, they're a little bit narrower, mesially, distally. Frequently said on the maxillary to be heart-shaped or three-cusp teeth. Again, one of the three-cusped teeth in the mouth with more of a central fossa in it. Although this is a third molar here, and it's well developed in the occlusal. It's got four, well-developed cusps and well-developed distal buccals, so they can be anything. The roots are commonly very short, frequently pointed. They can be totally fused. They oftentimes are curved. They're extremely irregular in the root form and shape. But generally they mimic the first and second, but are much less distinct and reliable. Mandibular first, again, very sharp on all the line angles. The seconds, both maxillary and mandibular, have a tendency to round on the line angles. Generally, we're always broader across the buccal portion of the tooth. It has a tendency to narrow as it comes to the distal. I should say broader across the mesial portion of the tooth, and it narrows as it comes to the distal. This tooth is said to be pentagonal in shape, with the distal surface containing two different surfaces on the tooth, being a five-surfaced tooth, if you want to say. It's also a five-cusp tooth, with our traditional cusps on the mesiofacial and distal facial, mesiolingual, distal lingual, and then we also have a distal cusp, which is located more prominently out on the distal marginal ridge area. Long central groove, we got our lingual groove. We've got two grooves coming out the buccal. One would be our Mesial-Buccal groove coming out and down on the buccal surface, and our distal buccal groove. So we got another distal buccal groove, or this is about the only distal buccal groove in the mouth. Our mesial marginal ridge being further from the cervical and the distal being closer to the cervical. This is basically the same in all of them, except again this first premolar, and I didn't point that out when we were covering it, but the mesial marginal ridge, because of this mesiolingual groove, is actually closer to the cervical than what it is distal. The only tooth in the mouth where that occurs on, and as I say, common question. We've got a root trunk which is short, trifurcation rather, or bifurcation here, frequently called a furcation, is close to the crown on it. We commonly have very deep, significant root grooves, both in the mesial aspect of the mesial root as well as in the distal aspect of the mesial root, which is down in the bifurcation area there. This leads so that this tooth generally always will have two canals in it. So the mandibular first molar has two canals in the mesial root, and that's a common question. Pulp horns are exactly identical to the cusps in relation to location and size. We've got a very significant pulp chamber inside of the posterior teeth. Our height of contour gets into the cervical area in our mandibular molars. The mandibular premolars, it was in the center, but in mandibular molars it's said to be in the cervical. And on the lingual surface, it's said to be in the center of the tooth, which is noticeably closer to the occlusal than the buccal surface. Again, our lingual cusps are our taller cusps, being further from the cervical, although as far as the size of the mass, our buccal cusps are the larger cusps, because again, that's what's occlusing into the central sulcus of your maxillary teeth. Remember, our seconds are characterized by being the four cusp, fairly rectangular, cross-shaped teeth. They've got a cross located in them, many of them, because of the equal four cusps. Actually, the cusps are a little bit broader. The tooth is a little bit broader to the mesial, across your mesial cusp, and has a tendency to narrow as it goes towards the distal and round a little bit on the distal portion of the tooth. But if you look at the individual anatomy on it, again, four cusps, central groove, you got one buccal groove, one lingual groove. Marginal ridges are basically the same. Cervical is the same. Height of contours are basically the same. Our lingual cusp is generally a little bit more prominent than our buccal cusp in height, not in mass, but in height, located closer to the lingual surface on it. The roots are more commonly well under the tooth and not bifurcated quite as close to the crown of the tooth on our seconds. Mandibular thirds are, again, almost a nightmare because there's no two of them anywhere near alike. Are frequently characterized by being round on all of its margins. The occlusal surface has a tendency to round in and be narrower. Our enamel is much thicker, it's much whiter, it's frequently decalcified, and whitish in its decalcification. The roots are extremely, extremely variable. We can have fused roots into one mass of root. We can have double roots. We can have well-sped roots, very commonly curved, often pointed. We frequently have a million and one what is called supplemental grooves in here. We'll have some of them which will be 4 cusps rather regularly. Some of them will be 5, real nice. Some of them will be 6 and have other tubercles on it. And you find every variation. Most variable tooth in the mouth is our mandibular third molars. If we look to the primary teeth, there are several things that are a little different. Generally speaking, we've got teeth which are shorter and have much heavier rolls at the cervical, and they're much broader. In fact, is the maxillary central is a common question because it actually is wider about a ½ millimeter or so from the mesial to the distal than it is from the incisal to the cervical, the only tooth which has that specific distinction, and they like to pick on it. The sheep teeth are generally said to be short and squatty, and enamel is much thinner. The pulp is much larger in these teeth. They all basically follow the same anatomy as the permanent teeth, with the exception of our first molars. And these have permanent first molars right back in the posterior here, but the first molars are in the area of the first premolars in the permanent teeth. Actually, any of the permanent teeth that are under the 20 primary teeth are called succedaneous teeth. And succedaneous tooth is a tooth which replaces a primary tooth. Your maxillary or first molar or second or third molars, none of these are succedaneous because they don't replace permanent primary teeth. They come in posterior to the primary teeth. But our first molars are significantly different than any other permanent tooth. And in our maxillary first molar, primary molar, it generally is said to be a 3-cusp tooth. It has 2 prominent buccal cusps and 1 prominent lingual cusp, sometimes a very small cusp out on the distal lingual. Sometimes it's just a tubercle, or they call it a small lump. Our maxillary second primary molar is identical in its anatomy to the first permanent molar occlusally. The 2 primary differences in these teeth is the cervical roll. The cervical roll is very heavy, particularly on the buccal. And if you remember, we got the Mesial-Buccal prominence or bulge, which is common in your molars, first and second molars, maxillary and mandibular, and very prominent roll at the buccal. And then, of course, the roots are spread wide, and they're very thin, ribbon-shaped, wide from the mesial, or from the buccal to the lingual, facial to lingual, and very narrow mesially distally on it. If you look to your mandibular, we find that, again, our second molars are identical to our first permanent molars. The second primary molars and first permanent molars are essentially the same. The primary molars are slightly smaller in overall dimensions. They've got the heavy cervical roll, and of course the thinner anatomy, larger pulps, and the things that whiter enamel and what have you that primary teeth usually have. But as far as the terminology of the cusps and the grooves and everything, it's basically the same. And of course the roots are the same, but very widely spread and very narrow ribbon shape, allowing for the succedaneous tooth to develop right in the bifurcation area. Our mandibular first primary molar, again, is the one that is completely different than any tooth in the mouth. And this is a 4-cusp tooth, rectangular basically in shape. It has a rounded mesial lingual line angle, and it has a very prominent and sharp, tall, pointed mesial lingual cusp, a cusp which is quite different than any other cusp in the mouth. It has a very short mesial cusp ridge and a very long distal cusp ridge. Comes to a sharp point. It's the tallest cusp in the tooth. It's pulled in towards the center of the tooth, making a little bit of a transverse ridge across between our two mesial cusps and our fossas into a mesial fossa and a distal central fossa area through here. But again, the cervical prominence of our Mesial-Buccal roll or Mesial-Buccal prominence is a very strong prominent characteristic on these teeth. In the appendix of the workbook, we've got a diagram which shows the cusp-fossa relationships of the various teeth. I think this is well to review. There seems to be a lot of questions on the boards in regards to cusps and fossas touching each other. Also, if you remember our eruption chart, we didn't require you to memorize it, but there are a lot of questions regarding the upper eruption chart, particularly as it reverts to key times, the beginning of this or the beginning of calcification or when it last calcifies, the beginning of eruption or the last eruption. It has to do with birth, what is happening at birth as far as the eruption and calcification, and you need to know general areas of time as far as when the teeth come in, but more specifically sequence. For instance, on our primary teeth, we get a mandibular central incisor erupting first, and then we get both the maxillary central and lateral before we get the mandibular lateral. And then we go to our first molars, maxillary mandibular. We skip the cuspids completely and come back and get the cuspids after our molars are completely in. And then we end up with our second molars, and the second molars frequently don't finish erupting until 2 years or after 2 years old, 26, 28 months. And so these are the types of things we need to know, general areas of timing and sequence in particular. And the same with the permanent teeth. They don't come in 1, 2, 3. And we need to, at birth, for instance, we've got our maxillary molars, which are calcifying, and a common question as to what's happening at birth. And then the eruption of them as to how they come in. I haven't seen them designate between maxillary molars and, or I should say, the first permanent molars and the mandibular central incisor. They both come in about 6, and there's no big differentiation there, but those are the first ones in the mouth. But you need to know general eruption sequences and general timing and first and last, and look it over and kind of get some patterns and trends from it. If you remember the one chart that we had in regards to our lengths and widths of the teeth, this is something that they hit fairly significantly, and the general trends on this area, I think it would be well to know. You remember in looking at your teeth that to begin with, on our centrals, maxillary centrals, our teeth are much wider from the mesial to the distal, narrower from the labial to lingual. And the same happens in our lateral. In our cuspid, this switches around, and we're wider from the lingual to the facial, a little bit narrower from the mesial to the distal, and that trend follows throughout the rest of our teeth. The lengths of our teeth, our cuspids are unquestionably the longest tooth in the mouth, maxillary being the totally longest, mandibular having the longest crown, and again, you'd like to remember the things that are the longest, the shortest, the biggest, the littlest type of situations. All of our widths of our premolars are identical, although our maxillary premolars are a little bit broader from the facial to the lingual than what our mandibulars are, but the mesial distal width are the same. In the posteriors, we start to catch up because in our widths that we are off in the anterior, because the maxillary molars are narrower from the mesial to the distal, a little broader from the facial to the lingual, and our mandibulars are the opposite. They're much broader from the mesial to the distal and much narrower from the labial or from the facial to the lingual. The one thing that happens in our crown lengths are the longest in the cuspid area. They get shorter as they go anteriorly, and they get shorter as they go posteriorly right up to the third molar. One of the common questions is about the thinness of the alveolar bone and infiltration anesthesia. The alveolar bone is the thinnest in the facial or labial area in the area of the mandibular anterior teeth. And oftentimes we can use some infiltration anesthesia in the area of our mandibular incisors. I hope this review will get you ready and get you thinking, studying in regards to your exam. It's just designed to be a review and to catch the highlights of dental anatomy.
You've been listening to a presentation from the University of Michigan School of Dentistry, which is dedicated to supporting open learning and open educational resources. This recording is licensed under the Creative Commons. It may be reused and redistributed for nonprofit use. Please attribute materials to the University of Michigan School of Dentistry and redistribute under this same license. For more information on how this and other University of Michigan School of Dentistry recordings may be used, visit www.dent.umich.edu/license.